What if I told you that most students get palpitations wrong? Not because they don't know cardiology enough, but because they're asking the wrong first question. Palpitations are not a diagnosis problem, they're a pattern recognition problem. And if you miss the pattern, you'll chase labs, imaging, and long differential lists and still get the answer wrong. In this video, I'll show you the one question that immediately narrows down to palpitations, how to recognize SVT in seconds, and the exact framework you can use on OSCEs and exams. When a patient says palpitations, don't jump to a diagnosis. First, you want to start with safety, then patterns, then key diagnostic frameworks. And for this chief complaint, patterns will do most of the work. So you want to ask questions about what they feel, the onset, duration, frequency, triggers, and any associated symptoms. Of course, make sure you do your red flag screens. And the goal here is palpitations are not a diagnosis problem, it's a pattern recognition problem. So let's explore how we can apply this framework to the case of a 33-year-old male presenting with palpitations. Before narrowing anything, let's start with a broad list of initial DDXs. We can organize palpitations into life-threatening causes, more common and benign causes, autonomic and physiologic causes, and then we can just have an other bucket. As we go through the case, we'll narrow this down to a working diagnosis and our top alternatives. So our first diagnostic fork is the most important step in the entire approach. Before anything else, we want to ask, what do they feel? Is it rapid and regular? Then you're going to be thinking SVTs. Is it an irregular beat? More likely AFib. If it's skipped beats, you could be thinking about PACs and PVCs. So if you get this question right, everything else becomes much easier. Now, let's build that full pattern out. Think of palpitations like a puzzle. You want to consider rhythm, onset, duration, triggers, and associated symptoms. For onset and offset, if it's sudden, arrhythmia, gradual, sinus tachycardia. Duration we can think of in seconds, ectopy, hours to minutes, SVT or AFib. If it's persistent, more likely a systemic cause. Next piece could be triggers. So caffeine and stress is a benign source. Exertion would be more of a cardiac concern. And if there aren't any triggers, then we can consider an arrhythmia. And then our last piece would be associated symptoms. So if there's syncope, that's more concerning and dangerous. Chest pain could be ischemia. Shortness of breath, more of a cardiopulmonary issue. Okay, so with all that in mind, let's review our case presentation for our 33-year-old male. He presents with episodic palpitations that he describes as sudden racing heartbeats that starts and stops abruptly. His episodes last 5 to 10 minutes and occur both at rest and during periods of stress. He denies syncope, chest pain, or shortness of breath. He reports no prior cardiac history. He drinks 1 cup of coffee a day, but denies stimulant or drug use, and he's a non-smoker. There's no recent illness, unexpected weight changes, or heat intolerance, and he's otherwise healthy and takes no medications. I've created an algorithm for how I like to approach palpitations. Let's put this into a system that you can use. So starting with red flags, we'd want to check for syncope, chest pain, exertional symptoms, or abnormal vitals. If any of those are present, we're going to send them to the ED for cardiac evaluation. If not, we'll use pattern recognition to help us narrow it down. So then we can think in 3 different lanes. So we have trigger pattern, systemic cues, and rhythm pattern. So with the trigger pattern, we could ask if there's any stress or caffeine that's triggering his symptoms. If so, then anxiety or substances are a likely cause. For systemic clues, we'd want to check for any thyroid symptoms. If those are present, we'd be suspecting hyperthyroid. And then with rhythm pattern, you could break that into a regular and rapid beat. That's more likely to be AFib. Versus an irregular beat, that could be divided into gradual onset, which would be due to sinus tachycardia. Or if there's skipped beats, more likely PAC or PVC are responsible. Now that we've asked focus history questions from our patient, let's revisit our initial DDX list and update that a bit. So based on this patient's pattern, there's sudden onset and then termination. The episodes are episodic, and there's regular rapid palpitations. So I'm thinking the most likely cause, my working diagnosis, is paroxysmal SVT. I'm going to keep premature beats like PACs and PVCs in my top differentials, along with anxiety. I think it's less likely that AFib is happening because his beat would be irregular otherwise. And he doesn't seem to have any thyroid or anemia symptoms, so that would be less likely a systemic cause. In an OSCE exam, your goal is not to necessarily definitively diagnose, it's to support your working diagnosis and rule out dangerous causes. You want your PEs to be targeted, not a mess of spaghetti. They should be informed by focused history taking. So don't forget high-yield exams of vitals, general appearance, and for this situation, a cardiac or heart exam is definitely warranted. Let's look at our top working options. We have SVTs, which would be indicated by sudden onset, episodic, and rapid palpitations. So you'd want to be sure to capture heart rate and then do a heart exam. So for our mock patient, they might be tachycardic and have a regular rhythm during the episode. If AFib was suspected, that would be indicated by more irregular palpitations. So again, you'd want to do a heart exam and you might need an ECG. For our patient here, we would have regular rhythm between the episodes. So that's less likely a cause. If there was PAC or PVC or those skipped beats feeling, there'd be brief episodes. So again, we definitely want to do a heart exam. And then for our patient today, that looks like that's normal, so less likely. For hyperthyroid, that would be more persistent and then systemic symptoms. So you'd want to make sure you do a thyroid exam. So you'd want to look for any kind of tremor, check their skin, other classic hyperthyroid symptoms. It couldn't hurt to check for deep tendon reflexes to see if they're a bit more excitable. And for our patient today, there was no tremor, no goiter, and DTRs were normal. For any anxiety or panic triggered palpitations, that's going to be more stress related. So you could check for general observations, what's their mood and affect, and then vitals would also be helpful. For our patient today, he seems pretty relaxed and everything is within normal limits. Lastly, anemia could be causing palpitations, and it's possible with some exertional symptoms and fatigue. So you'd want to be sure to check for any kind of conjunctival pallor. Again, looking at vitals. And for our patient today, let's assume that everything was within normal limits for that. Okay, so at this point, let's see how we might present our assessment. We have a 33-year-old male who presents with episodic, sudden onset palpitations lasting several minutes without associated syncope, chest pain, or dyspnea. Episodes begin and terminate abruptly and occur both at rest and with stress. He has no significant stimulant use, substance use, or systemic symptoms to suggest metabolic causes such as hyperthyroidism or anemia. This pattern of onset and offset that's sudden, his regular rapid palpitations, and episodic nature is most consistent with a paroxysmal SVT. Premature beats remain a consideration given the episodic symptoms, and anxiety is still possible, though the abrupt onset and termination favors an arrhythmic etiology. Before we wrap up, I wanted to put 3 traps that students often make on your radar so that you don't make those mistakes. So first would be skipping severity of the assessment. So you need to check for syncope. Is there any chest pain? Is it exertional? Because that could be missing a dangerous arrhythmia if you don't avoid that trap. Irregular rhythm pattern would be next to consider. Remember, pattern is your key for diagnosis here. And then listing diagnoses too early. So not asking about onset, duration, or triggers. Again, pattern is going to be your strongest discriminator in a case with palpitations. Let's summarize our palpitations framework. We have safety first. Be sure to rule out dangerous arrhythmias. Don't forget your classic pattern with sudden onset plus rapid and episodic palpitations. That's highly indicative of SVTs. And don't forget your key diagnostic forks. So asking whether it's regular or irregular, sudden versus gradual, duration, and triggers. Bottom line, pattern predicts rhythm here. If you're preparing for OSCEs or clinical exams, I've linked a couple high-yield resources that were helpful for me below. Dane's Advanced Health Assessment and an OSCE Pocket exam guide. And if this framework helped, check out our full chief complaint list, where we break down syncope, shortness of breath, and chest pain. For each of these chief complaints, I'll give you a structured framework that'll hopefully make it easier and less stressful. Thanks for watching, and I'll see you in the next one.